Hello, everyone. My name is Gabriele, as Nikki said, and it's a pleasure as well to meet all of you. Some of you I know very well as well. So today we are going to share the experience of Medair in implementing the MAMI Care Pathway. First with a pilot, and from this pilot some lesson learned, of course, a recommendation to expand the MAMI activities as well in DR Congo, in the eastern part of DR Congo. And just to say, Medair is not new in implementing MAMI. We started in 2018 with Astrid, that is who is already present here as well. In Bangladesh, at the time it was the CMAMI program, CMAMI Care Pathway, until 2022. Culminating as well in a small operational research, was an observational study, which was presented in the MSF Pediatric Days in November 2022, and then we share as well here in this group in 2023. Then, of course, from Bangladesh, we moved to South Sudan, and then we indeed implement MAMI in Pibor County. The presentation was done by Dr. Wendy in June 2023 in this group, and then we expand activity as well from Pibor County to Lair County. Today, we wanted to share this experience in different contexts, conflict-affected area in the east part of DRC, in the provinces of Ituri and North Kivu. And we can see here this beautiful picture of this mother, Amina, with her son, Katoto. We will share the inspirational story of this mother. Because really it gives hope as well for all these people who are really vulnerable in these areas. And MAMI can really help on this, can help really giving a bit of hope as well to all these underserved and vulnerable people. And then next slide, thanks. And this is also, this picture link also with the focus of Medair as a strategy in DRC, DR Congo, focus on life saving to prevent and reduce morbidity and mortality among the most vulnerable. And among the most vulnerable, there are as well these dyad mother and infant under 6 months in this conflict-affected community in Ituri and North Kivu. Improving access to essential quality health and nutrition services. Next slide, thanks, Ray. So the technical design of our approach in the program in general, in the RC program, is to support the Ministry of Health Facility. Usually we support more than 40 health facility on average. Sometimes we reach also 50, 60 health facility in the 2 provinces through incentive of staff, supply of quality medicine, quality support supervision, and this keyword integration, which is very critical as well for MAMI, integration of health, nutrition, and WASH activities with primary care in particular, but also referral to secondary health care. Community health and community engagement as well is so significant, important, and key as well for activity like MAMI, we will see later. We do response to emergency, in particular to outbreaks. We see here in this slide on the right, on the bottom, this Mpox treatment center that we built in Goma in July 2024, even before WHO issued a public health of emergency of international concern for Mpox globally. And then we continued this treatment center for 1 year until July 2025. We respond as well to emergency like fresh displacement and of IDPs and returnees as well waves. The funding are from the European Union, from the US State Department, and the Swiss Development Cooperation. Next slide, thanks. So let's start with this MAMI pilot. This MAMI pilot was done where? It was done in the IDP camp around Goma. The name of this IDP camp is called Bushagara. We see here a picture, hosting around 20,000 people. This was done at the beginning of, let's say, 2024, in the period between May and July. And the pre-work was done at the beginning of 2024, in particular with planning and sensitization meeting with the staff of Medair in their facility inside the Bushagara IDP camp. Their facility was run by Medair and was providing mainly primary care services. We did also sensitization meeting with the Ministry of Health, called as well PRONANUT, the Protocol National pour la Nutrition, so National Nutrition Protocol program, and selected a facility in the health zone around Goma. This health zone was called Health Zone of Niragongo, where Medair had 11 health facilities supported. To be clear, we didn't run the pilot in those 11 health facilities. We just wanted to sensitize them to know for the first time what MAMI Care Pathway was. And then after the sensitization as well, we did a training in the health facility inside the IDP camp, in the Medair health facility, training on for the staff involved in the MAMI Care Pathway in April 2024. We include as well in this training the CHW, community health worker, and we sensitize as well the lead mother of care groups in the camp. The care groups, a kind of mother-to-mother support group, was as well supported by Medair. Finally, we plan and conducted exhaustive mass meal screening in the Bushagara IDP camp for all the infants under the 6 months to determine a bit the MAMI caseload. And this was very important because we wanted to understand whether or not to add as well some staff to the organigram of the health facility to accommodate for the new needs and the implication as well that a new MAMI Care Pathway could pose in the activities of the health facility. The next slide, thanks. So here we see the result of this MAMI screening to understand a bit the caseload. At the time, we use a different threshold for infant less than 6 weeks, MUAC, perimeter brachial less than 110 millimeter, and between 6 weeks and 6 months of age, we use a MUAC of more than or equal to 110 millimeter and less than 115 millimeter. We identify in this way that around 15.5% of the under 6 months in the camp were indeed having many anthropometric risk factors. So next slide, thanks. So these allow us to indeed determine the way that we wanted to implement the MAMI Care Pathway in our facility. And then in that sense, we added 2 additional staff to the MAMI Care Pathway, to the facility. In particular, one was a MAMI called in French receptionist. So let's say MAMI person doing the rapid screening at the entrance of the facility, and for all the infant less than 6 months, as well as we had a second staff called the MAMI counselor. We identify as well among the staff already present in the health facility, the so-called MAMI focal point, who was very critical to ensure as well that assessment of the MAMI diets was done in a proper way, as well as indeed ensuring that there was integration between the MAMI Care Pathway and all the other maternal, child, neonatal health services or newborn services inside the health facility, such as, for example, postnatal care services or growth monitoring promotion, EPI, and, for example, the SFP day for the breastfeeding women. We, of course, refer a MAMI infant with dangerous signs to the stabilization center, which was not supported by Medair, which was as well a bit far away, was called the Canariucinia Stabilization Center, supported by a different actor. And then we ensure as well the MAMI outpatient care with clinical assessment by IMCI nurse, as well as a counseling by the MAMI counselor. The next slide. So let's talk a bit about the successes and the challenges of this pilot, and then we will move to lesson learned and to recommendation. First of all, the successes, the Pronanut, so the Ministry of Health, authority of the health zone on Iragongo, agreed with and welcomed the approach. 70 infants were enrolled, and DIAS, infant mother, were enrolled in MAMI Care Pathway, of which 52 of them were under the age of 2 months. Community engagement was established with care groups and CHW. Challenges. The implementation of the MAMI in other health facility was clear since the beginning was not possible. This was clear since the beginning because for them this was an additional activity overloading the provider schedule. So they clearly communicated to us, this is very good activities, very meaningful, very significant. We cannot do without additional resources. The stabilization center was far away, according to the mothers, and a lot of complaints from them. We were able anyway to refer two of these children to the stabilization center. There was also at the beginning a low motivation among the mothers to attend the MAMI service. And the mental health problem among the mothers were not addressed. No comprehensive training on MHPSS, a lack of qualified staff. The next slide, please. So some lesson learned. The mass screening at community level, there was a need to organize a specific training for the CHW, otherwise they will get confused with all these different thresholds, and as well with the different age category, because usually we know that the CHW target an infant between 6 months and 59. The strategy to identify MAMI focal point at Bushagara Health Facility level facilitated the integration and the understanding as well of the MAMI care pathway, as well as to ensure quality through a proper assessment. The mothers, as we said before, there was initial failure to keep the appointment due to poor understanding of the care pathway, and thus there was as well a lack of motivation. The idea to offer half of bar of soap together with as well the integration of the messages and understanding at community level through the support group of care groups proved effective. We will see in the next slide as well about the care groups. And finally, another lesson learned was that the adaptation of the follow-up visit. In order to fit and integrate with other services, the follow-up visit were more flexible, based as well on whether or not the child or the mother had some specific appointment for EPI, GMP, rather than TSFP or indeed postnatal care visit. We see here, for example, our indeed on the bottom our CHW, so community health worker trained as well, receiving really training on MAMI. The next slide, please. So here we see a beautiful picture from the ADP camp, di Bushagara, with our group of lead mothers, so care group, and the presence of promoter and women volunteers. So these women volunteers are called lead mothers in the care group of Bushagara, gave a strong and positive contribution to the implementation of the MAMI approach. As you may know, these care groups are composed of lead mothers. The mothers receive some lesson on how to improve the behaviors on health and nutrition and the WASH topics. And the lead mothers, then they meet themselves with a group of neighboring women called, indeed, these neighboring women groups, 10, 15 people, and they cascade the lesson to them in a way that there is really an amplification of this lesson to the targeted community. And the mothers, through the lesson, can understand how to improve the behavior, can discuss how to solve problems, can share as well life experience. In this way, there is as well peer support group, peer as well education. So in that sense as well, having as well a mother understanding MAMI, going through the MAMI care pathway, and in this way as well becoming MAMI champion would increase as well the credibility of MAMI and the interest as well from the other mothers about this MAMI approach. The next slide, please. So some recommendation from the pilot. We see here on the left, Christine. Christine was as well in Bangladesh with Astrid. She remember very well. And they started as well with the SIMAMI in Bangladesh in 2018, 2019. So Christina was as well key to start in DRC with the MAMI Care Pathway version 3. So provide a budget for motivating breastfeeding mother, baby soap, we said before, linens, provide a budget for additional staff, identify as well a MAMI focal point. Make useful supply equipment available, so not to have only one baby scale. We run into this mistake, and then when the baby scale broke, we had to run to find another one. So doing supervision as well to continue to build the capacity of the MAMI provider, identification of priority problems for counseling during each visit, proper assessment as well, and data collection is very important as well, very key. Continue to support the capacity of the CHW and favor the presence as well of community-based support groups, like, for example, care groups to increase the community outreach and support. The next slide, please. So we saw before this picture of Amina and her son Katoto, inspirational story. 40 years old, mother of 10 children, 4 times displaced the last time was in this IDP camp of Bushagara. Female headed household, baby 5 weeks old, born low birth weight, with a breastfeeding problem, lack of confidence from the mother, concern of milk not sufficient. And she went through the care pathway. I went there to meet her this day last year. I was there. And again, she was happy with the support and the guidance received. And also she was happy to be part of the care group, to have the possibility to receive from the care group, but also to give to the other mothers something. And she became a champion as well, a MAMI champion in her care group. The next slide, please. So Bushagara was so important. The pilot was from May until July 2024, and the activity continue in Bushagara as well, and the MAMI activity continue, but continue only until January 2025, because in January 2025, with the crisis in Goma in particular, M23 coming to Goma, taking over from the government, and they oblige as well all the IDP camp to be emptied, to be dismantled. So Bushagara IDP camp ceased to exist in January 2025. All the people, returned back to their place of origin. And the legacy of Bushagara IDP camp is there. It's there because thanks to all these recommendations, and from this recommendation stemming out from this pilot, we were able to expand the MAMI into additional MAMI sites. One in the Ituri province in the health zone of Fataki, and the other one in North Kivu province in the health zone of Kalunguta, specifically in Bula health area and Kasebere health area, with the funding as well from the US State Department at the time, BHA. And this time we wanted to implement the MAMI site not in a Medair directly run health facility, but in the health facility of the Ministry of Health, supported by Medair, but run by the Ministry of Health. And we really used the recommendation from the pilot, MAMI pilot, so we added as well to additional MAMI staff. And we were able from October 2024 until August 2025 to screen even more than 5,000 diets. Screen. Here is written more than 4,000. I check again, it's more than 5,000 diets screened. And we were able to enroll 736 pairs, diets, 365 male infant and 371 female infants. The next slide, please. So the reason for admission were sometimes overlapping as well, but the most recurrent were growth retardation, prematurity, feeding difficulties as well, adolescent mother, and then mother suffering from acute malnutrition. The reason for exit at the time of, let's say, censoring the data at the end of August 2025, we had 301 exit at 6 months. 180 were referred to the community YCF, 30% of them to the TSFP, and 10% of them to the OTP. The total exit before the age of 6 months were 54, with 30 referral for hospitalization, 22 defaulters, not so high, thanks to the combination as well of care groups present in all the locations where we were doing MAMI. So in not only in Bushagara, but as well in Bule and in Casebere, as well as to death. The next slide. So we were able in a few days ago to replace as well Bushagara camp, which of course abruptly was stopped in January 2025, with a new site for MAMI. Thanks as well to the funding, private funding that we were able to get. So in October 2025, we opened in Kinigi Health Facility in Katoya zone in North Kivu, a new MAMI site. Dr. Bonshi was there, providing as well the training with Dr. Lucien. Medair trained 7 staff of the Kinigi Health Facility, 3 nurses, 1 midwife. And as well, we were able to, of course, add 2 additional staff, 1 triage staff, 1 MAMI counselor. We as well trained 4 staff from the health zone team, so for the Ministry of Health, and 3 Medair staff, 2 nurses and 1 community engagement. The 2 nurses are nurses supervisor, ensuring the supervision of the health facilities, and 1 community engagement. The next slide. So the way forward, this is the second to last slide, continue coordination with the Ministry of Health, continue advocacy at cluster level, both health and nutrition. We would like to start with nutrition cluster, first of all, for institutionalization of the MAMI Care Pathway at facility level. Inclusion, if possible, as well in the future in the national guideline. Expanding activities, of course, ensuring as well and strengthening the breastfeeding support also at the stabilization center level. Strengthen community outreach component to mother support group or other groups, and explore a way as well with other partners to strengthen referral. We need to start as well thinking more seriously as well the mental health and PSS component, as today still, as we mentioned before, remains a weak point in our MAMI Care Pathway, and research for new funding opportunities, including private funding. The next slide. So I would like to thank, as we mentioned before, Christine, Community Engagement Advisor, Dr. Lucien, our MAMI trainer, Dr. Bonshi, Nutrition Coordinator in DRC, Dr. Olivier, our Senior Health and Nutrition Advisor, the Pronanut, with the Ministry of Health, the Health Authority in Nyiragongo, Kalunguta, Katoy, and Fataki zone, all the staff in the facility of Bule, Kinigi, Casebere, as well as the community in Bule, Kinigi, Casebere, on top of the Bushagara IDP camp community, and our fund, donors from US State Department and DORA Foundation. Thank you very much for your attention,